Assalamu alaikum guys, how are you? I hope you are feeling fine. The preparation is going well. So today I gonna discuss a very important part of the USMLE exam, a very important section that is microbiology. And among microbiology, I am gonna discuss the fungal infections. Now you know that fungal infections are one of the most important topics on the exam day. And the fungi are classified into three groups. One are the systemic fungi, the other are the opportunistic fungi, and the third one are the cutaneous fungi. So, systemic fungi and the opportunistic fungi are very important for the exam day. So, it must be on your fingertips for the exam. So, I will be discussing in a way that it is very easy for you to pick the answer on the exam day, right? So, what we gonna do? We will be discussing buzzwords, high yield points, some different case scenarios, so that each and every topic becomes absorbable and digestible for you. So let's proceed further. So first, we will be discussing the systemic fungi, and there are basically four more most important systemic fungi: the histoplasmosis, blastomycosis, coccidiomycosis, and paracoccidiomycosis. And among these four, three are very important. That is histoplasmosis, blastomycosis, and coccidiomycosis. But before we really start the topic, there are some general points which are very important for each and every systemic mycosis. So one thing that all these systemic mycoses exist as a dimorphic fungus. What is a dimorphic fungus? Basically, there are two morphologies. One is the yeast form and the other is the mold form. Mold form exists at room temperature while the yeast form occurs inside the macrophage. So they are dimorphic fungi. Second important thing is that all of these have symptoms which are similar to granulomatous diseases, that is TB and sarcoidosis. They all have general symptoms of these two. So you can get confused in the question that it might be asking of TB, but it is not TB, it is histoplasma, plasmomycosis, or any of the systemic mycosis. So how can you differentiate on the exam day? So the clue to differentiate or distinguish these from TB or sarcoidosis is the history and the lab values. So each of these systemic mycosis are endemic in specific regions of America. So what we will be doing is that we will be going through each of them in detail. And first of all, we have to discuss about the histoplasmosis. So the causative organism of histoplasmosis is the Histoplasma capsulatum. It is a dimorphic fungus that exists in two distinct forms depending on its environment. The mold form appears as hyphae in soil environments, while the yeast form transforms into intracellular yeast within the human macrophages. So talking about the transmission and the epidemiology, the most important thing, as I discussed it earlier, is the endemic regions. So in histoplasmosis, remember the Ohio or the Mississippi River valleys or the regions of the Midwest US, but specifically Ohio and the Mississippi River valleys are the most important regions where histoplasma is endemic. Remember this. Ohio, Mississippi. If you see in question that a patient presents from Ohio or Mississippi River Valley, the first thing comes in your mind is histoplasmosis or blastomycosis. The first thing which comes into your mind. Second thing, there are some other risk factors which are related to histoplasmosis, and the most important among them is the exposure to bad or bad groupings, which is written here. So how they can give clue for bad groupings? They can share that the patient which has come have a history of cave exploration. So this is how they can give you a clue of bad or bad groupings exposure. So what is the pathophysiology? Pathophysiology is simple that the spores are inhaled into the lungs from the environment, the macrophage engulf them, and there is intracellular multiplication and then dissemination. So what are the presentations? Basically, there are three presentations of histoplasmosis. One is the acute pulmonary, second is the chronic pulmonary, and the third one is the disseminated. So acute pulmonary comes in immunocompetent patient, and it is a mild flu-like illness which is self-limited. And in chronic pulmonary, you get the symptoms of TB like cough and cavity lesions and weight loss. But if the disease gets disseminated in an immunocompromised patient having CD4 count less than 150, then you get some systemic symptoms which are hepatosplenomegaly, fever, weight loss, and pancytopenia. So it's a spectrum, like starting from a mild flu-like illness, which can proceed to or progress to fever, weight loss, pancytopenia, hepatosplenomegaly. And what is the test of choice for diagnosis is the urine or serum histoplasma antigen. On the exam day, if you get a case of histoplasmosis and the history tells you about the histoplasmosis, you reach a diagnosis of histoplasmosis, and in the end they ask what is the diagnostic test of choice, then the answer is urine or serum histoplasma antigen. What is the treatment? Now remember, generally in all of the systemic mycoses, if there is mild disease, we give azoles, hydroconazole. It is a very mild disease, then we can observe the patient. There is no need of treatment. But if the disease gets severe, if the disease gets disseminated, then we can shift to IV amphotericin B. So you have to see what is the condition, but on step one, they usually don't assess you on the treatment. It's basically step two, CK part. What can be the complications? So one thing we discussed earlier is the chronic pulmonary disease, which can progress to lung fibrosis and respiratory insufficiency, and the other is a disseminated infection. And in disseminated infection, what happens? There is severe weight loss, pancytopenia, liver dysfunction, sepsis. And one thing which is very important, which we will also be discussing in the endocrinology module, is the adrenal insufficiency. Yes, histoplasma adrenalitis leading to hypotension and electrolyte abnormalities. So if you get a case of which is giving you a history of histoplasma, there is risk exposure, there is the endemic epidemiology, and in the question you see that there is an emergency condition where there is hypotension, the electrolyte abnormalities, that is hyperkalemia, hyponatremia, metabolic acidosis. So in that case, you can think of adrenal insufficiency due to histoplasma. So this can be a very important thing on your exam day, which you can't miss. Or a differential diagnosis. So as we had discussed earlier, one of the most important differential diagnosis is tuberculosis. But in tuberculosis, you get acid-fast bacilli, and there is chronic cause. And in blastomycosis, there is a characteristic yeast appearance, which is broad-based budding, and there are also skin or bone lesions. And in coccidomycosis, the region is different, and there are large spherules with endospores, and there is history of or there is presentation of erythema nodosum. And in sarcoidosis, there are elevated ACE levels, calcium levels are elevated. So the biochemistry is abnormal. If you see the same presentation, but the biochemistry differentiates sarcoidosis from histoplasma. And lymphoma have its own symptoms. So what are the buzzwords? What can you see on your test? What can you see on the exam day? So one thing is the Ohio or the Mississippi River valleys. So it is endemic region, high yield geographic clue. Second is the bed or bird droppings. Third is the intracellular yeast in the macrophage, which is pathognomonic microscopic finding. And fourth is the TB-like appearance. So this is the histoplasma. This is the comparison of different systemic mycoses. And there are three case scenarios. The first scenario is a patient of 29-year-old man with mild fever and cough after cave exploration in Kentucky. So you see the cave exploration. There is a risk factor for histoplasm. Chest X-ray shows bilateral hilar adenopathy and calcified nodule. Symptom resolves spontaneously. So this is a case of mild histoplasma infection, which is in acute pulmonary histoplasma infection, which is in immunocompetent patient. What is the case two? 38-year-old woman with HIV or AIDS, CD4 count 80. So you see that the CD4 count is less than 100. So when you see CD4 counts, the differentials eventually come into your mind. But the diseases have CD4 counts less than 100 are particular. They all have their own values. Presents with chronic fever, weight loss, pancytopenia, and hepatosplenomegaly. All four signs and symptoms we have discussed in the histoplasma part. Peripheral smear shows small oval yeast inside macrophages. This is the pathognomonic microscopic finding. So what is the diagnosis? The diagnosis is the histoplasma. What is the case 3? Chronic cavity. 65-year-old man smoker with COPD presents with cough, weight loss, and night sweats. Imaging reveals upper lobe cavity lesions. Sputum AFB negative. Now, if we cancel this line, sputum AFB is negative, then we might think of TB because the symptoms are very much like as in the presentation of the TB. But uh, this line, sputum AFB is negative, rules out the TB. And serum antigen is positive for histoplasma. So this is how in chronic pulmonary diseases, there is a chance of histoplasma if there are risk factors present. Is it clear? So we are concluding now for today's video. We have discussed histoplasma in detail. Inshallah, in the next video, we will be discussing about the blastomycosis. Take care of yourself, like and subscribe, and please share to your colleagues also. Thank you.